and welcome. We're very, very excited to join you today with session number 2 of this mobile response and stabilization learning community. Today, we're going to focus on someone to respond. And I am so happy to be able to bring this conversation to all of you. My name is Liz Manley. I work at the Institute for Innovation and Implementation at the University of Maryland School of Social Work. And I'm joined today by, I would like to say some of my favorite people, but I'm probably going to say that a lot over the course of the next year around these conversations. But we have quite the panel for you today. Let me just take a minute to introduce some of my friends in this work. First, Danielle Gasparini, who is the Division Director for the Children's Services at CPC Behavioral Healthcare. That is an organization that's been working on mobile response and stabilization world for quite a long time in New Jersey. Danielle, you want to just wave and say hello? That'd be great. We're joined by Dante McKay, who is for some of you, you will know him very well. He is the director for the Office of Children and Young Adults and Families in Georgia Behavioral Health. I want to say hello, Dante. Thank you for joining.
Hi.
And last but not least, we have Hazelyn Pilgrim, who is the executive director for the Family Support Organization of Essex County in New Jersey. You want to say hello, Hazel?
Hello, everyone.
Fabulous. All right, let's get started. And before we actually get started, let me just say, throw questions in the chat box. We'll be paying attention to them. We're happy to answer them. If for some reason or other we don't get to your questions, I will make sure that your questions get answered. So again, thank you for joining us today. Let's start with the learning objectives, just so folks know what the purpose of today is, and that's to define the concepts that are foundational to mobile response and stabilization. Today, we're going to focus a lot on that response piece of the team that responds. We're going to identify the importance of child-specific assessment as a foundational element to mobile response and stabilization, why that's so important in this work, and identify potential strategies to include a plan of self-care for individuals, supervisors, and organizations. And certainly we have some folks who can bring some real conversation to this. Like all of our conversations around mobile response and stabilization is really not just about the discussion about crisis and the crisis situation that family is experiencing, although we'll talk about that, but it's also about this idea of how do we get help to folks in a time when seeking help could be really challenging, right? In our last session, we talked about someone to contact, and that someone to contact really helps this idea of the system being not so confusing for folks to be able to access services and supports. And I wanted to walk through real quick what the mobile response and stabilization continuum is, and we'll probably do this quite a bit over the next year or so around some of this work, just so folks really get used to some of the language and culture shifts that are necessary in order to truly embrace the concept of mobile response and stabilization. And for folks who are new to us today, I just want to define mobile response and stabilization as a real customization of a crisis system specific for children, youth, families, and young adults. Okay, so in the mobile response, we talked about someone to contact. That information is available. We're happy to share it if you haven't seen it. Today, we're going to talk about someone to respond and what that means when that's someone to respond. And in this conversation, I want to start really by talking with or asking Danielle Gasparini to just help us understand what the actual response looks like. So let me just step back real quick, let folks know that in New Jersey, there's a single point of access. That single point of access is going to do the triage piece, and then they're going to connect to the mobile response team. So Danielle, can you take it from there and just talk us through a little bit of what that looks like when you get that call?
Sure. So when the call comes in through that central access number, it gets directed, if the family lives in my county, to my county, and either myself or someone from my team will pick up that call. The operator on the other end of the call will give us a brief description of what the family described to them as their situation, and then they connect us together, introduce us, and then drop off the line. At that point, we will talk with the family and figure out how it's best to see them. So we can respond to them either physically and meet them wherever they are within an hour, or we can set up an appointment within 24 hours. We can also see them via Zoom to do a telehealth type call if that works out better for the family. I always kind of joke around and tease and say, we meet the family, wherever they are. As social workers, usually that means sort of theoretically wherever they are, but I mean physically wherever they are. So we will see them either at their house or their friend's house or the mall, if that's where they are, or the convenience store, or, wherever they are, we go out and see them. We usually go out in pairs so that, if a family needs to talk, privately with, a response worker, they can. We always want to bring the family and the youth back together. But once we're there, we do an assessment, and that assessment is our crisis assessment tool, which is from the John Lyons set of assessments. We go through that assessment, and we're looking at all life domains of the youth and their caregiver to figure out what their needs are. We're typically at a home about an hour and a half or so as we kind of hear everyone's story and do our assessment. At that point, we complete a safety plan, so that way we know that when we leave the family, that if a crisis does arise, before we are able to link them with services, they have a little plan in place, which would include our number to call us back. And then we're also looking at what those linkages are going to be. So they could be to community type care, like an outpatient, or it could be to our intensive in-home services, which we have access to. So we can, then link a family to an in-home therapist who can come out and see them for, a couple hours a week in their home or via that telehealth setup. I think I'll pause there, right? Because I don't want to go too far into it, right?
And let me even just connect one of those dots. So today we're going to talk about that first part of mobile response and stabilization. And what we want to really clarify for folks is and you can see in this chart, there's a response that's with a 72-hour component, which means the team can be out in that home within 60 minutes, as you just heard. And that first initial response is really a 72-hour component that allows multiple things to happen, including that child-specific assessment and the beginning of linkages to other things, including the idea that we'll be linking to stabilization services or a system to support, which we'll talk about in our next conversation, which is coming up in just a couple of weeks. So we're going to stay really kind of focused and pretty tight around the conversation today around the response. But I also wanted to just real quick, Hazelyn, if you want to talk just a little bit about what that peer support work looks like. And I in particularly think it might be interesting for this group to hear how the warm line that the family support organizations, that's part of your work, how that might be helpful in connecting families, even initially, to mobile response and stabilization.
Great, thanks, Liz. So Warm Line for us is a family from the community that has a need and has an immediate need for help. They're looking for someone to connect them to a solution to the challenges that they're having. That person can call our office number between office hours or even after hours, and we will respond the next business day. And in those cases, we sometimes walk the family through accessing that single point of entry through which they can obtain mobile response services. Another way that Warm Line works is if the family has already been through the system and has had now a new situation arise, they can call the Warm Line and we can assist them with connecting them, reconnecting them to community-based resources and services so that perhaps they don't have to go through the full-blown services that they might have had for another child. Warm Line is available to anyone in the community. The parent must simply call and ask for help, and we respond.
Thank you. So one other comment I just want to make, and that is, when we talk about Warm Line, right, and even that single point of access, we're talking about the public approach, right? We're talking about any family, not just limited to a particular payer or a particular population, but really the full scope of children, youth, and families within the state of New Jersey, certainly for Danielle And that will lead me to my question for you, Dante. Thank you for joining. And we heard a little bit in our last month with some of the comments and feedback in the chat around what great work Georgia's doing around that single point of access work, right? And maybe you can just take a minute and talk about Georgia's model for that single point of access.
Thank you, Liz. Hi, everyone. And I saw some of my Georgia colleagues drop their name in the chat. So shout out to Georgia. We refer to it actually as a PPOE, a preferred point of entry, because it is not the only access pathway for services. Some of our crisis services have a walk-in component, but it's really helpful when it goes through our Georgia Crisis and Access Line, GCAL for short. It is a 1-800 number currently. It'll be linked to 988 sometime in the near future. But it is a statewide service supported by DBHDD, the Georgia Department of Behavioral Health and Developmental Disabilities. It is a combined service for children and adults, so age 4 and above. Georgia has 159 counties, so it operates statewide in all 159. 24/7, 365. The response time that we measure is 59 minutes or less. And in some instances, we are below that. In some of the more rural areas, we're above that. It is a model that includes a pair, so 2 individuals, one being a licensed clinician. And I don't know if I started by saying it's a little different in terms that it is a mobile crisis response service. And so it is crisis stabilization and referral linkage if necessary, either to like a crisis stabilization unit, or if they're able to stabilize the team, then it's linkage to community-based service in the next day or after.
Thanks, Dante. And listen, I think it's important, that distinction around mobile crisis, right? But we invited you to part of this conversation for a couple of reasons. One is the amount of work that Georgia has done to really move this conversation along, to really build the tools that are necessary and infrastructure and attention to really addressing the needs of folks within Georgia who are experiencing some crisis situations are really important to talk about. And at the same time, I think it's important to talk about, some of the challenges, right, that are, part of the work of building a true continuum that gets to that full-blown, how do we get to every family within a community 24/7, right, and what that looks like. So my next question for you, Dante, really is about, so once that call comes in, and let's say a parent, or a caregiver of a child or a young adult themselves are saying that, they're experiencing a crisis situation and that crisis is defined by themselves, what happens? What's the next, what does it look like in Georgia?
Well, there's sort of kind of a screening process. So the operator will screen to see if, according to some criteria, if a dispatch is warranted. And if it is, then, depending upon where the individual is located in the community, it could be, street, school, what have you, they'll dispatch a particular team. Mm-hmm. The service is, we are, I guess our target audience is behavioral health and intellectual and developmental disability, including autism. And so depending upon what the diagnosis is, the presentation will depend on who gets dispatched. Mm-hmm. We also include peers as a part of our team, and Georgia has, several different peer practitioner types, from parents to youth to adult to substance use disorder. So just depending upon what's going on in that crisis moment, mm-hmm. The operator will be assessing all of that in rapid real time, and based upon what they're hearing, and they will dispatch a team out.
So next question, Dante, since we talked about the role of you called it, I forget what you call it. It's not a single point of access. What do you call it?
A preferred point of entry, PPOE.
POA. You also talked about 988 coming in, right? And what the, that switch over to 988. Is it I have a couple questions about the 988. Is it your expectation that the 988 will then become a single point of access and that all things will flow through 988, or that the entry points will remain the same, but 988 will be a larger connector? Does that make sense?
I do. I'm tracking. I think to be determined. So there are folks smarter than I am. I know enough to be dangerous, but there is I guess a 3-person kind of project lead that has swept in a lot of different people in terms of their lenses, and to kind of co-plan and see what changes, what stays the same. But it's fluid, and a lot of people are meeting pretty much daily.
So that sounds like really the conversation that's happening around the country, right? And we're really, really anxious to see how this is all going to work out in the long run. But I don't want to move too much away from the focus of someone to respond. But before we do that, Denise, I think you might have a relevant question we might want to get to. Do you want to share that question?
I do. Thanks, Liz. So it started with Jen asking the panelists' thoughts on having separate teams that do youth and adult, the two separate, versus a unified system where teams are trained to respond to any age. She's seen the literature stating that separate teams is best practice, but would like more information on the why. And then Christine added to that, to Jen's question, saying same goes for answering 988 calls. So it really goes to both what Dante and Danielle were speaking to.
Sure. So I'm gonna take it, and then I'm gonna give the panel an opportunity to add any additional things. So let's start with the first adult versus child teams going out, and why best practice is really about having child-specific teams. One is, the first part is, children really require a particular skill base in order to engage both the young person and the parent and caregiver in a meaningful way. Can you train teams to do that? You can, but the other challenge that we have is a resource challenge that becomes really important. So when you have to choose between an adult who's experiencing a true psychiatric emergency and real worrisome, concerning behavior, right, that we really need to address, and we wouldn't argue that that's necessary. Children's behaviors actually don't always escalate that point. In a world of mobile response and stabilization, our conversation is that we're addressing what is the beginning parts of a crisis situation as identified by the adults around them. But the challenge is when we have to pick who we're going to work with, teams that are trained in both will go to the adult and the child's needs will go unmet. But that means that we've missed an opportunity of engagement. We've also missed an opportunity to help parents really navigate a system and learn how to actually be the one to manage those crisis situations in the long run. But more importantly, we lost the trust of both that parent and the child. And that trust that we lose in the beginning parts of the systems engagement carries on throughout the course of that young person and that parent's time in the behavioral health system. And we hear that from 18-year-olds, 19-year-olds, 20-year-olds who will say, the system is horrible and it won't help, right? We hear that all the time. In systems that are not organized in a way that really specifically designed to meet the needs of children, youth, and families. So that's one of the reasons why. But and another really important part of this is that child-specific teams are looking for particular things when it comes to children, right? So we know that children are experiencing some shift and change that is worrisome, but that worrisome behavior may not be externalized in the way that it is for, say, an adult who might be experiencing some crisis situation. So and maybe that young person is saying they might harm themselves, or they are refusing to get off the sofa, or they had a really negative experience in school. the quicker we can address those challenges for that young person, help the parent organize what needs to happen next, and get that young person back into school, the more likely it is that we're going to be able to address these issues for young people in the future. So the more experienced the team is, the more skilled they are, the more tools they have around their tool belt, the more likely it is that that young person will not only get back into school, they'll graduate from school, and their behavioral health needs will be met in a more meaningful way for both the young person and their families. Hazelyn, I'm just going to give you an opportunity first off to address this particular issue.
Well, ditto to everything that you said, Liz. I would only add that from a parent perspective, I think it's really important to connect around understanding the child's developmental stage and their needs. And if you have someone that is accustomed to working primarily in adults population or with adult populations, that sometimes can be tricky. And so parents need to feel confident that the individual who come out to support them or to work with their child and with them understands something about child development, understands and can relate on a very detailed level and personal level to what that child may be going through and experiencing, and knows the resources that they can connect them to in the community. Because one of the things we always like to see as peer support providers is that the youth and family are connected to natural supports, that they know who's in the community that they can go to when formal services are no longer being utilized or no longer necessary. And that's good for both the system and the family, because we know that as children get older and their needs change, it's not the institutions that are going to raise them, it's the community that's going to support them.
Absolutely, right. So one other point I'm going to make, and then I'm going to let Danielle jump in, and then Dante, you're right after that. So in the difference between the adult and child model also is around who's the identified individual for whom we're working to serve, right? So in the mobile response and stabilization model, we are saying that parents and caregivers' voice in this conversation is imperative for us to be able to make meaningful change. And with that, it means that we are actually addressing the anxiety and the challenges that families are experiencing because they're in a position in which they're watching as things are happening for their children, and they are asking, what do I do about it? And we're answering the question, we're going to hold your hand through this and get you to the other side. And that the investments, the long-term investments in doing that type of work are powerful, not just in the children's system, but powerful in the adult system as well, because what we are helping both young people and their families learn is how to manage when these symptoms might come on in the future, right? What do you do? Who do you call? What can we expect? What does it feel like? And then what skills can we bring to ourselves? As an example, for a young person who might be experiencing some suicidal ideation, as an example, supporting young people in that experiencing and making sure that families know and understand what they need to do in order to help that child can be a long and very powerful strategy to help when that young person might feel like harming themselves again in the future, right? And so that they have strategies and tools to use when things get more complicated or they have an elevated stress system because things are happening in their lives. So Danielle, you're up next.
So I was just going to say the other, I think, important component is we are talking a lot with the community, the schools. And so as issues come up and, the schools reach out to us and say, there was this incident that happened at school, it's affecting a lot of the families in the community, then we're able to educate ourselves on maybe some, other tools that might help the family and the community. So I think having these really open community conversations with the other caregivers in the community and the other system partners is really important, because that helps us do our job better when they can alert us first, when something happens, it's either tragic in a community or we know that's going to affect the community at large. So it's a really big piece for us here in my county. We work really very close and collaboratively around anything that might happen in a community that affects our children and families. So I think you guys covered so much of it, but I just want to add that piece because I think it's so relevant to how the whole system works for us.
Exactly. So, Dante, do you have things to add? I know that you have a model that looks different, but I'm wondering what your thoughts about adults versus child model.
Nothing, I don't think anything different to add to the points that have been made previously. I would say this in terms of just the evolution of our mobile crisis service. It's changed a lot in the last couple of years or so. Just there's a lot going on in the state of Georgia, has been and will continue. Maybe about 2 or 3 years ago, we re-procured the service. And so there was a behavioral health kind of contract and component, and then there was a IDD contract and component. There was no specialty autism related. And so a lot of things were happening at once. And so when we re-procured the service, we re-procured it for a single contract that was, inclusive of all the different disorder types, if you will. And so that evolution has continued.
Yeah, I think the question about evolution is really important, right? So as we talk about building crisis systems, I think it's important to know that the mobile response and stabilization, just as an example, or another part of the crisis continuum, let's just talk about stabilization or engagement strategies. They're going to learn, that you're going to learn and grow from the experiences that you have, from the population that is showing up and needing help and assistance, and where the data takes us in terms of putting time and resources. And certainly training and the workforce pieces are really important in this particular conversation. But what I think is important for folks to know is that it is not, most states don't land at 24/7, 365, total population of engagement. They start with particular things, right? They start with maybe that one, I'll call it a no wrong door approach, single point kind of idea. Teams are going to go out. Maybe it is a mobile crisis model that looks at a more, crisis in a more defined approach than, say, the parent or caregiver is going to define the crisis. What we like to talk about here, and what I think is important, is wherever your starting point is, we would like you to move the ball down the field to get to a larger group of individuals, to get there with a well-trained workforce who is then supported through the tools that they use as they bring them through the door. And that the feedback that we get from young people and their parents and their caregivers is really essential in making innovations as we move forward in this work. And that all of the models that we'll talk about over the next year, all the folks who will be engaged, this is part of this conversation of how do we get from where we are to more ability and access and more skilled workforce for all of our children, youth, and families across the country. So that's where we're at. Denise, I think you might have another question that we might want to take now. Do you want to share that?
I actually have two. Your questions have a snowball effect here. It's great. So the first question came on early on from Michelle saying, do you require consent from the parent or legal guardian in order to activate crisis response? And Malia just added she's also interested in how you navigate consent for treatment in crisis, and if you do, and if you require legal guardian participation in assessments. What if the caller's at school? Do you dispatch to the school without the parent being there? And if you complete an assessment on the side of the road, do you complete the full hour and a half there? So a lot of loaded. So we're talking consent and we're talking assessments, and how do you get it all done?
Sure. So I'll take it from a policy perspective first, and that is, the New Jersey approach is that when a parent caregiver calls the access center and asks for help, that's the first verbal consent. And that the team that's dispatched has the capacity to get signatures and conversations around consent. So I just want to put that out there that, that's kind of how it works. There's been a lot of questions recently around what happens if a young person under the age of 18 who can't consent for themselves, or in a state that has consent that started at 14, how does that work, right? And I'm just going to say from a policy perspective, as a decision maker in the policy world, when I was at the Department of Children and Families, we would say that 14-year-old who's asking for assistance, we would want to look at other strategies before we would, I think, bring in mobile. And those other strategies might be, can we immediately connect them to an outpatient appointment? Can we connect them to school-based mental health services? Are there things that we can do? Because we would see that young person as consenting, and because we would worry about leaving family and caregivers out of any conversation around a child's behavioral health need. But having said that, those are just strategies, not necessarily drill down policy around it. And I'm going to let the folks who are actually doing some of this work in the field right now talk about that. So let's, Hazelyn, it seems like a really good question for you. So why don't we start with you?
Yeah, I wanted to respond specifically around the question of schools calling, because often we're asked that question. We do a lot of workshops with school personnel around how to access services and also some of the strategies that we found effective. When a school calls for help, we encourage them to connect with us, with the parent on the phone. And sometimes we've actually gone to meet with them at the school with the guidance personnel or whomever, and had the conversation and walk them through accessing our single point of entry here in New Jersey. So that's one of the strategies that we've used. It is very important that we stay true to the values and principles of family voice and choice. And so we always want the caregiver to be informed, aware of the options that they have, and aware of how to access the services and feel supported in that process.
Danielle, you want to add on that?
Yeah, and so what we're able to do for mobile response is we can respond to a school, say a caregiver is stuck at work and they can't get to the school in that moment. If we have their consent, obviously through that access point phone call, we can go to the school and meet with the child there, and then just have an appointment time later to go meet with the family. So we don't want to lose that, initial, like, we want help now by postponing it till later. So we want to kind of jump while everyone's interested. So, definitely that. For the telehealth calls, we send out all of the signature forms through a DocuSign, so we can get all of those signatures pretty easily too, even if we're not seeing someone in person.
Yeah, really helpful, right? So let me just ask you a quick question, because it comes up a lot. It might come up with the group on this, who are listening in today, and that is, what happens if that 14-year-old doesn't want their parent to know, right? There's a multitude of reasons that might be true. And way we've conceptualized, mobile response and stabilization is that it is, a service that is driven for caregivers, right? To caregivers be the driver in the driver's seat around that. I'm just curious whether that has come up for you around, because sometimes I think we might have intervened on your behalf before.
So we typically, we haven't really gotten too many cases of children who are under 18 who do not want their caregiver involved. A lot of times we get, the youth who are 18 who don't want their caregiver involved. And my agency feels really strongly that we want to have somebody else from that family, from those informal supports involved. So if it isn't a caregiver, could it be an aunt or, the neighbor or something like that? So we're always looking to kind of pull in the people who might be in their lives that aren't the actual a caregiver per se. But I have to say, I haven't had the experience, unfortunately or fortunately, of say a 14-year-old calling Perform Care, calling the access number without a caregiver to this point, which I guess is saying something because I think this is my 12th and a half year. So yeah, so far we haven't really gotten that.
And I think that's because of the other tools in the tool belt that are used, right? So school-based mental health as an example, or, the connection to outpatient and the ability to try and figure out how to resolve some of those issues so that young person gets the assistance that they need. But that we really work hard to ensure that young people have that extra support system engaged in this particular conversation. Nante, I would love to hear what you think about that.
Well, it's a gray area. It comes up pretty frequently in terms of consent, and there are a number of different considerations. In fact, one of our regional directors pulled me aside at a meeting last week to talk about a consent concern. I mean, there's state laws around it related to consent. Their schools have policies related to it. Consent is preferred, but then there are instances where there's an emergency, and our provider network is directed to act in that moment to respond to that emergency, and then think about consent after they have intervened. And so, because of that, it is a gray area. It's a prickly area for us, to be honest. And the situation last week was one where the youth was suicidal, and I don't remember how the mobile crisis team became aware of her, but her mom was not in favor of them, coming to the house, and so that was the prickly part about it. The considerations are liability or police involvement in some cases, and so it's just one of those areas that it's hard to kind of define and kind of person-centered, if you will.
Yeah, no, I think it's a complicated question. And I think one of the reasons why we're hearing the experience in New Jersey is because mobile response has been around for almost 20 years, right? So that folks know when and how to reach and assist for help. But at the same time, I think it's about when and how to use other tools in your tool belt, right? In terms of some of this work. So, but I think that consent issues are not easily resolved, right? They are complications, and it is a complicated question that I think leaders need to think about when and how, and when and how it operates. How does that, the folks in particular, as 988 comes up, how does that impact, right?
Yeah.
What is going to be the impact when a young person under the age of consent maybe can have the ability to consent for behavioral health treatment, but still have to go home and live with their parents, right? How do we work through those particular challenges? And I think this is going to be one of those conversations that we're going to need to spend some time really thinking through. So, so thank you for the question, whoever asked it. We appreciate it. Keep the questions coming, comments coming. Any resources you have, please use the chat. We love that. Thank you. All right, I'm going to try to get through to the next slide, just so that we can work through some of these slides. Mobile response and stabilization is really designed to get to interruption points, right? To move away from the idea that emergency departments are a good place for children to get care. And the reason we think that emergency departments are the best place for children to get care is because, first of all, it's just a tough experience for children. It can be very traumatizing. And it also, we have the wrong message, right? When it comes to, for young people in terms of what we're trying to communicate. So if we want them to get the best care, then we actually have to deliver a new message. And so we want to address these interruption points in a way that makes sense. And that 72-hour component, right, to mobile, that parent, caregiver, maybe they're being pushed by the school to call because their child might be experiencing some suicidal ideation, or maybe something else is going on in the school and they're getting ready to suspend or be concerned about. And how does mobile response step in? And how does that work happen to keep young people out of emergency departments? So I'm going to start with Danielle. Maybe we can talk through what happens when you have this relationship with schools in a community that say, we would prefer to use mobile response and stabilization than to use the emergency department for this particular young person.
So we do presentations in schools all the time. So most of the schools have my cell phone number. So they're pretty quick to give me a ring if they're having some kind of, an issue. But I think one of the things that we do really well when we have an issue like you described, Liz, is we're able to, a lot of times the school is kind of just thinking in the realm of like, what schools do, and the caregiver is just focused on I need to like figure out how I can make my child feel better, and sometimes they can't have a productive conversation because everyone's kind of trying to fill like the need that they have. And so where we step in is, we will help explain each person's perspective. So we'll explain where the caregiver is coming from to the school and vice versa, and then see how we might then be able to mediate something that might be really helpful. So say if the child is, refusing school because in their first period class, there's someone in there that's, bullying them or something that's making them really anxious, we might be able to talk to the school then and say, well, is there a chance we can switch classes, or for the time being, can they come into school at period 2 until we can kind of come up with a solution? And so we'll kind of do that mediation between the school and the family to help move things along. On the same vein, instead of sending a child to, the emergency department, we're able to go and do our assessments in the school. And, that saves the school a lot in terms of, just upsetting, just how the flow of the school day, as well as this poor child who's going to be traumatized by that experience and costing the family so much money to go into, emergency room and having to get blood work and all that medical follow-up. So we really just step in and we'll be that mediator. Sometimes it's a matter of, meeting the child at the school with the parent and walking in and kind of, just literally holding their hand and say, we're going to walk to the guidance office and we're going to kind of do this together. So I think it's hard to like answer the question because it's not cookie cutter per se, but we're really looking at the situation and see how we can intervene and mediate.
That's helpful. Thank you. Dante, I was wondering if you wanted to talk just a little bit about the ability for mobile crisis to be able to interrupt some of these points that would take young people to emergency department.
I was sitting here thinking about just Georgia's system. So we have a pretty established school-based mental health program in the state. In Georgia, there are about 2,200 public schools, and our school-based program called Apex was in maybe just shy of 800 of those. Right. And one of the metrics for that program that we track is referrals to higher levels of care. And it's in the single digits. Just prior to the day, jumping on, I looked to see of how many, in this current state fiscal year, how many dispatches have been to schools. It's 740 in this current fiscal year out of like 21,000 or so. And so I think our school-based program, and I don't have a good feel for how it's connected to mobile crisis, but the providers are already in the school, but Apex is not in every school. So my assumption would be that the 740 schools may be those that don't have an Apex provider in the school, and there may be a need to dispatch there. I think that is some of the work considerations that, as we continue to evolve our mobile crisis and move into mobile response service, to see how those existing programs are currently linking together.
Yeah, that's pretty powerful, right? And that data is pretty powerful just in that story that you just told around how much work is getting done in the schools. And then I would love to know where those calls are going to schools. That would be good data. I might have to follow up with you on that, Dante. Hazel, and I was curious about your thought about maybe the parents' perspective, just as a thought around that whole emergency department experience.
I think parents, having gone to the ER with some parents, I think the point of entry the preferred point of entry would be something other than an ER. I think it's very traumatizing for families to have that experience. I've sat with folks in the ER. Oftentimes the personnel are not familiar with the children's system of care or the resources. And the waiting times in the ER while the child is in crisis can be untenable both for the child and the parent. So certainly we're fortunate to have a system that alleviates some of that. But yet there are times when it's necessary. And the concern is the ability of the workforce to manage the needs of the children when they present, particularly those that may have a dual diagnosis of mental health condition and an intellectual or developmental disability. That's perhaps the hardest population to provide for in that kind of a setting. The medical model itself can be challenging for families. You know, we really look at children in the context of the family and the community, the environment in which they're living and what's going on in their lives. And services through the ER tend to take a very medical approach that is not as holistic. And certainly from a wraparound standpoint can be challenging.
That's for sure. That's for sure. So let's just continue this conversation around care pathways. I just want to touch on this slide real quick. And in particular, talk about that when we talk about care pathways, we're talking about the impact in three places, right? So systems have to think about it. Leaders within systems have to think about policy and access and assessment and, you know, all of these kind of ideas. But we also want to understand what is that youth, that is that child, what is that young adult's experience as they're going through this care pathway. And so the more information we have about the experience, whether that's in mobile response and stabilization, whether that's in emergency departments, whether that's in mobile crisis response, the better off we are at really trying to figure out how it is we're going to use a care pathway that is most helpful for young people and their families. And we really need to understand what the experience is for providers too, right? Those who are actually doing some of this work. What's really cool about this particular panel is we have Dante who's doing that systems pathway work. We have Hazelyn who's really navigating with families, and we have Danielle who's in that program pathway and working through policy. So I just wanted to point out that this is the way that we organize and think about some of this work, and all of this partnership and communication is incredibly important as we talk about if we're going to shift care pathways away from emergency departments as the first step for children and for not just children, but for children, youth, and young adults. And that we are going to work with parents and caregivers and those who care about these young adults in a way that says emergency departments are not the best place for us to start our work, right? That there are other solutions to some of these challenges, whether that's a mobile crisis outreach model or whether that's mobile response and stabilization. And I want to talk real quick about the two components, and really we're going to spend a lot of time on that, or we're going to spend more time on the 72-hour component, because next time you come and join us, we're going to spend time on that up to 8 weeks of stabilization. So today, Danielle, we talked briefly about what happens, but maybe you can walk us through when you go to in the home of a family who's asked for assistance and you're going to respond. First of all, let's just say, because it's a public health approach, you're working with young people who have intellectual and developmental disabilities, right? Which is truly one of the core groups of folks who use mobile in New Jersey. But also you might potentially be working with children who have some level of complex behavioral health need that might have gone unidentified, some trauma, right? Trauma experience. So in other words, what I'm saying is pick up the phone, parents call, you're not quite sure who, right? all the scope of what's happening. So let me just start by my first question to you, and that is, has there ever been a time when you've walked into a family's home, or your team has, where you've said, we shouldn't be here?
I don't think so. So the first thing that popped into my head is we walked into a family's home once where the child probably should have went to the ER because they were suicidal. They did have a plan, they did have means, and they did have intent. But then we were there, and then we were able to ease that transition to get them to that emergency department. So I guess I could have easily answered your question, said, yes, we shouldn't have been there that time. But I think we were there that time, and that was so important for that family, for us to be there to help them and transition them to that.
How about, have you ever been there when you've said, oh, this isn't really a crisis?
So a few times my staff has said that, they'll get off the phone and they'll say, I can't believe we're going there. And I'll say, well, what's the call? And they'll say, this girl, she got scratched by her cat. Like, is that really a crisis? Like, why do we have to go there? I'm like, I think that's probably just scratching the surface. And, not to be funny, but, and also, the family crisis is subjective. And so, there's more to that. And so you can't make that judgment call in this moment. We need to find out like why that family called and why that's a crisis for them. So yeah, those are two of like the things I thought of.
So when you get there, I mean, part of the work is that face-to-face within the hour, and the second is that, the parent and caregiver define the crisis. The third is crisis de-escalation that happens when you're in the home. And then that really important assessment conversation, because that's going to happen, right? The assessment, the going, the sitting, the working with families, the walking through the crisis assessment tool happens. Can you sort of talk a little bit about that? Because there's a little mystery out there about how the crisis assessment tool is used. And I just want to swap out that this could be other tools, and we'll talk about those in a minute, but just the process of sitting through the assessment and what that means.
I mean, I think that you're like one of the things that you said was the crisis de-escalation. So when we get there, we're kind of walking into sometimes a pretty hot situation. Maybe the child really isn't so happy that their caregiver called us and these strangers are sitting in their living room. Or maybe the caregiver is really upset because they have tried so many times to help their child, and their child is, being resistant or, being, aggressive or something towards them. So, I think that first few minutes, or sometimes 30 or 40 minutes, depending on what it takes, is really sitting down and kind of meeting everyone where they are, and, kind of just, easing everybody's mind about what we're going to do, why we're there, and what our scope is. I think that takes sometimes the most time, and is such an important time to do. And then from there, the crisis assessment tool has questions, both that are just inclusive to the child, but also about the caregiver and their ability to care for the child, and how this situation is affecting them. And also to look at the other domains that might be going on, that caregivers' medical, situation, their housing situation, the use medical situation. So if a child is say older, or seems like maybe they're not going to be really forthcoming in front of their caregiver, we would ask if we could maybe talk to each of them privately, to give them each a chance to kind of give us some information without the other one hearing. And that is usually very, very helpful. Our staff, they're trained on knowing what the questions are in the assessment, but they don't read the assessment like an inquisition. So we really like that assessment to be more conversational, and starting like, tell me why you think that you're mom, your dad, your aunt, you're called us. Like, why are we here? What's upsetting to you? And so starting with that, to hear what information might be provided before we have to ask some of those probing questions. What I find is a lot of times in just that conversational back and forth, all of those questions on our assessment are answered without us having to be inquisitional. Yeah. So there's
kind of the design of the crisis assessment tool, as it is the design for the CANs, is really that conversational, and including the FANs, right? The family and needs assessment tool, which is the companion to all of that. It's in that CAN suite that makes sense, right, across the system. So it makes a sense. Listen, I think Denise has a question around assessment that might be coming up. So maybe we'll take that question now.
Thanks, Liz. So Danielle, this is it's all about timing. So we had woven into one of our prior questions, if you complete an assessment on the side of the road, you completed the full hour and a half there on the road, which is one extreme. To the other extreme is in New Jersey, do you have the entire 72 hours to complete the assessment, or does that need to be completed at the first face-to-face? So when and how long?
So do we complete the assessment on the side of the road, the whole assessment? I guess it sort of depends, right? So if a family is really engaged and we're having that conversation, wherever it is we're having that conversation is private enough, we're not going to interrupt that flow to say, hey, let's move to another place, as long as we're in a safe place and it's private and we can continue to have that conversation. So maybe we might move to another place, but maybe we won't. I think it's, the family is in a lot of ways really in charge of how that dispatch goes for us. And in terms of that 72 hours, so those first 72 hours, how it works for us is we are pretty much at the beck and call of that family for the first 72 hours before we get into that 8 weeks of stabilization that I know is going to be talked about next time around. So in that first 72 hours, the family can have us come out to see them as many times as they need us, call us as many times as they need us. And certainly if they are exhausted and, they don't want to finish talking, to finish all of our paperwork, certainly we can go back out and complete that paperwork within those first 72 hours before we have to start that stabilization if that's needed. That's certainly something that we're able to do. Honestly, I don't find that very often, if I can add that. Most of the time, once a family dials that 1877 number and kind of gets us going and we're there, they kind of want to finish it. They don't want to leave any of it for later. They just want to sign everything, get it going, and knowing that, later that day or tomorrow morning that we're going to be able to start linking them to services, seeing what we're going to be able to do for them. So while yes, we can, usually it's not how the process happens. I think that was everything you asked. Did I miss anything?
You covered it. Thank you.
And Dante, I was wondering if you could tell us, what is the assessment process in Georgia? What assessment tool do you use, and how is that engaged in the outreach or the work that happens in mobile outreach?
Honestly, I'm not really sure about that. It's a question I would need to take back. From a larger systems perspective, we prefer the CANs.
Right.
But I don't know if that is being used in the mobile crisis process.
All right. So that's one of the questions that I'm going to be following up with you, Dante. Good question. Thank you for your honesty around that. Hazel, and I have a question around the parents' perspective around just the idea of picking up the phone part, right? Like, what is the courage that it takes to pick up the phone and admit to the public system that you need assistance?
It's truly an act of courage and also sometimes desperation for families, because by the time they've gotten to us, they've had a fair amount of searching and trying to find connection to resources. Oftentimes they express feelings like, I thought I was the only one going through this, because there's still the issue of stigma attached to having a child that has behavioral challenges. And I think that what I hear from parents most often is that it's a relief when they find that A, they're not alone, that
Right.
there's a family organization that has parents with lived experience that can help them navigate those calls, and also that there are people on the other end that know something or understand something about children's development and the services and supports that are available.
Mhm.
The flip side of that, I don't want to give the impression that it's perfect. One of the frustrations that I hear from parents is that oftentimes they don't know exactly what they need. So they don't have the language
Right.
to express, well, this is the service that I need. And so we hear a plea for very clear, transparent communication around what's needed, what is the eligibility criteria, and what are the service options. And we hear this especially from the parents of children with developmental disabilities who are included in our system of care.
Yeah, so let's talk about that just for a second. So, I was fortunate enough to be I think I'd say that now. We're fortunate enough to be the assistant commissioner when the integration happened for youth with intellectual and developmental disabilities. And one of the challenges really was that families wanted to be able to ask for particular services, but they weren't necessarily the right match for those services. As giving an example, a lot of families were asking for respite care when really mobile response would have been a better fit for what they were describing in terms of what they were dealing with in moments, right? And respite would be an important part of the continuum to ensure they had access to, but certainly not the only part of the continuum, right? So how do we navigate that, right? How do we help families be able to get the right service at the right time for the right duration in a way that is meaningful?
I think it's all about having good and courageous conversations with the family, helping them to articulate a family vision.
Mhm.
And then from that, looking at realistically, what is the need that you're trying to fill? As I said earlier, sometimes parents don't have the language because the language that we use in systems is different from the way parents, traditionally think. They think I need relief, I need a
Yes.
babysitter, I need,
Yeah.
something very concrete. And the acronyms that we use also can be very confusing. So I think greater transparency around what are the service options. There's a wonderful tool that's being used in New Jersey now with the DD population that I think holds potential, and it's called Charting the Life Course. And it's really helping parents to look at what is your vision and what are the things that you need in order to get there. And not sort of pie in the sky, but really very realistic, concrete, match to the child's developmental age and needs,
Mhm.
and having those conversations. Because as you said, Liz, sometimes parents were asking for things because they heard that this parent got 5, units of this, so I'll ask for that. Or I heard that, this is a great service or a great program for this, but if it doesn't match the need for your child, it's not going to work. So really helping them to define the needs
Mhm.
based on how the child presents and what they're experiencing, I think is key.
That's really important. I think a really important part of the conversation. Dante, I know that Georgia has a very strong peer support, continuum, work, advocacy, all of that. A lot of this work in peer support was really grounded in Georgia, and they have a real rich history. I wondered if you wanted to share some of your experiences around the peer support work.
Sure. I mentioned earlier that there are a couple different types of peers. The Guild is robust, and the adult peers and the individuals with lived experience are much more seasoned. That work has been around 20 plus years or so. Newer peer practitioner types relate to our parent certified peer specialists and youth certified peer specialists. Couple years back, and so the service was that peers in that providing that lived experiences as a part of a service was only limited, or was only available through high fidelity wraparound. We amended our state Medicaid plan to make it a statewide service, and really have been working to build capacity around that. We were making some progress before the pandemic, and now we lost that progress, and we're actually resetting to try to back, recapture that progress. Now, when we re-procure the mobile crisis service, we added peers, but there are no youth. Although they are eligible to participate, we don't have them. We're trying to grow them in state. And so that's where things are as it relates to youth peers.
It sounds like, I mean, listen, the experience I think from many of the states I've talked to about this is that it's a really challenging group of young folks, like that, in particular in that real mobile response world, right? To have, or mobile crisis response, to have a youth peer part of the conversation. But it really is the direction that we want to begin to think about moving in. So I have one more question about youth peer support. Do you have a particular certification process, and is it designed for, like, particularly for youth peer support partners, or is that part of the work in your vision in the future, Dante?
We do. It was really handled. So for the adult work, there are vendors that we work with, and so over the last 12 to 18 months, we moved. It was managed in-house by my office, but we've also moved that work to a vendor that is holding regular, recruitment sessions and trainings, and managing the certification part of that. Georgia remains the certifying body, but we are partnering with a vendor to kind of, help us in that work. Before the pandemic, and so it's interesting, again, talking about evolution. So there were more peers for a period of time than there were available opportunities to work in the state. Now there are plentiful opportunities to work in state in mobile crisis and community-based services, so on and so forth. And now we're trying to build the workforce to match those opportunities. And things like having a car for youth is very important to be able to, to dispatch, or being, far enough along in their recovery that they are not, triggered by these crisis situations. So just some of the things that we have learned along the way.
It's really helpful and important work around bringing youth peer support up, and then get, the ability to have it be part of your Medicaid state plan is really powerful, and a lot of the tools that a lot of states are really thinking about. We talked about, I think, all of this, so I just wanted to touch real quick on the assessment tools, and I'll just cover this real quick for this group, and that is that states are using really the child and adolescent needs and strength tool suite, right? Either the crisis assessment tool, as New Jersey is, or the brief CANS, as Ohio is, and some other states are contemplating. The collaborative assessment and management of suicidality, or the CAMS, that we know Oklahoma is using. And some states are embedding the Columbia suicide severity scale into their CAT or their CANS as part of it. So those are just some of the assessment tools for folks to consider and to think about. All right, let's move to systems coordination, collaboration. And so Hazel, now I want to start with you. We talked about children and youth and young adults with intellectual and developmental disabilities as a real population of young people who have complexity. And I was wondering if you want to just talk a minute about how important it was for New Jersey to try to move those systems together so that parents didn't have to do this, and starting with that mobile response and stabilization call, how they could get connected to other things.
Well, I think it's been a great opportunity for parents, because prior to moving into the children's system of care, there was no resource for parents of children with intellectual and developmental disabilities that came out to the home or to the school to help with these issues with the immediacy that mobile response can. We find that parents are accessing services in unprecedented numbers. And we see in the last year alone, a rise in the children in the 3 to 5 year old category. A lot of that is coming through mobile response. And in New Jersey right now, there's an initiative with mobile response and Montclair State University, which has a Center for Early Childhood Mental Health and Autism, where the workers are being trained to better understand and serve this population. So I think those are some great innovations that are happening here. One of the opportunities that we've had as an agency, as a family support organization, is to partner with our local Regional Family Support Planning Council, where we educate parents about the children's system of care, how to access those services. We jointly offer workshops and support groups that are frequently attended by educators from the different school systems. Pediatricians have participated, and other community organizations that are serving this population, many of which are run by parents. So it's been a great way to connect families to not only the formal services, but some of those community-based services like the karate programs, the summer camp that's run by the mom who has a child with autism and is now doing it in 5 or 6 churches around the community. The YMCA, where we've had some success in even training staff there in how to be inclusive and how to use one of our programs here in New Jersey, the Nurtured Heart approach, to work with these children and their parents to achieve outcomes so that they can be included in the community-based settings.
Thank you. Danielle, I was wondering if you want to talk a little bit about the child welfare work and the use of mobile response and stabilization for children who are going into foster care.
Yeah, so I guess it's probably about 6 years now, which seems like a lifetime ago, that the initiative started, where if a child is being placed or replaced to either a kinship placement or a foster placement, that mobile response is called. And the reason for the called mobile response is not necessarily for us to help the child with the reason for the placement, but actually to help them acclimate to the placement. We'll help link to services that will help with the reason for the removal, but our role is to help that child settle into that new home environment and to help that new caregiver understand what that child might be going through in the coming weeks, their trauma response. And so that it's been a wonderful initiative and collaboration between us and Child Protective Services, and they keep really great data on it. And what they have found is that children are less likely to have a disrupted placement when mobile response is involved, and we can intervene and help them acclimate to that placement.
Yeah, it seems like an aha moment when you said, hey, I think we should try this, right? But the goal of that was to mitigate against a traumatic experience for children who were touching on another system. So that moment, right, that moment in time when that happens. And I think New Jersey's data across the board demonstrates how important partnership that was. But these other partnerships are really important too. So not only with child welfare and juvenile justice and family courts, education, as Dante talked a lot about the school-based mental health services being so incredibly important. We want to talk about law enforcement real quick. I talk a lot about law enforcement for folks who've heard me talk before about the teams responding without law enforcement in a responder type model. But let's talk about what the role of law enforcement is, right? Because you also have great partnerships with law enforcement, and law enforcement is one of the folks who are calling perform care sometimes with parents on the phone, right? So do you have any of those experiences that you want to talk about? Aislinn, we'll start with you.
Next week, we'll have the privilege of sitting with some Newark police officers and a grandparent who was introduced to the children's system of care by those police officers when her grandchild was about 15. And that young woman has recently, in 2021, completed her bachelor's in social work after almost failing out of high school. And her grandmother attributes this to the police department having an awareness of the children's system of care and saying, call this 877 number, get connected, and then she was connected to the family support organization. So next Friday, we'll have a celebration of that success story. But it is important to educate the police officers. And I know that We've had several successful collaborations here with police departments who have taken a number of trainings, whether it was mental health first aid, youth mental health first aid, and some of the other work, the CIT trainings that they do. And they can be very effective partners and sharing information with families. And as they do community policing and really get to know the people in the community, they become a trusted source of support.
Thank you. Danielle, did you want to talk about anything around the role of law enforcement?
Sure.
Or,
I mean,
by the way, you could hit anybody on this list if you wanted to.
so in our county, mobile response as well as our other community partners take place in the CIT trainings for our officers.
Mhm.
So we have, a direct line of communication to them in this training format. We can tell them about what we do and how we can help them and how they can access us, which is really amazing that we have that direct line of communication with them. And as a result of that, a few of the departments will often come up afterwards and ask me if I can come just to talk to the rest of their officers,
Mhm.
so that they can all get a firsthand, listen to what we do. And they unfortunately taped me one time so they could show it to all of the shifts, which, was really great. But, it's always just a little awkward, right, to know that you're being recorded. But I know I'm being recorded now too, but that's okay. So, but I mean, it's really great that that the CIT trainings open it up where they want not only for that one representative to go back, but also for us to go back and talk with the officers. The other thing I can touch on this really quick is the pediatricians. So we actually have attended, the pediatricians usually have a conference about, well, with COVID, it hasn't happened, I guess, in the last year and a half or so, but we're usually invited to the pediatricians conference where we set up a table and we can explain all about mobile response services, and they take, our, the perform care number, and we teach them how if one of their patients is completing one of those PQ9s and they feel alerted to some issues, that they can, instead of reverting to the emergency room, they can call us and we can intervene. So that's been really great. We've gotten enormous referrals from pediatricians' offices, and I think we've averted a lot of ER visits with that collaboration.
Thank you. Dante, I know that you could probably speak to quite a few things on this list. I'm going to ask you a particular question because you are truly an integrated system with children's behavioral health, adult behavioral health, and intellectual and developmental disabilities. And I was wondering if you wanted to talk about how that coordination is so important for families.
Well, you asked the question earlier in terms of what I heard was, who is the client? And so from my perspective, from the kids director perspective, our work, our supports are anchored to the youth. And so peer support is available to the parents, but the child remains our client. And, if you were to talk to my colleague in adult mental health, that parent may also need some, behavioral health supports. And so in that way, there's some overlapping work that we do, just broader than mobile crisis, but related to what we call transition to age youth, but also to the families. Mm-hmm. And so it's just, it's a work in progress. And so where does one office start? Where does one office stop? But from my seat, we focus on the child and connecting them to, mobile response or any community-based services to support those long-term needs.
Thank you. Thank you. Listen, I know that we're getting close, so I told you I'm going to work really hard to get through our slides. So let me get to the last slide that I think is important today, and that is the goals of mobile response and stabilization really are to support and maintain youth in their current living environment. And that is one of the goals, in other words, is to have that young person be able to sleep in the bed that they slept in the night before, right? That crisis situation is defined by the young person and their family. And that really the goal is not just to have young people not touch on emergency departments, but really to limit the inpatient touch, right? For inpatient hospitalization for a multitude of reasons. One is that there is an over-reliance on inpatient care for young people who will not benefit from it, right? So we want to make sure that if a young person is going to be an inpatient, that young person is going to benefit from that experience. And what we know is that that's not necessarily true, that some young people end up in inpatient care because the adults around them don't really know what to do, right? So one of the questions that I'm going to have in a second as we move through this is, what's your data kind of look like around that? And I'm a little familiar with both states' data, but we'll talk about that in a second. The second is to engage youth and families by providing trauma-informed care, or that trauma-informed lens, which is so important, to promote and support safe behaviors in home, schools, and behavior and community. And the goal really is to have that young person not just stay in their own bed, but really get back to school as quickly as possible and to keep them moving forward. And to reduce the use of emergency departments and higher intensities of service like residential care. And assist youth and families in accessing and linking services and supports, including the link to the higher intensity service. So let's just talk real quick about this issue of them individuals staying in their own beds, right, at night. New Jersey's data, I'm just going to share, is like 96 to 98%, and it's been 10 years worth of data that looks that way. And right, Danielle, I got that right? Okay. And that includes child welfare, as we talked about. That includes young people in foster care. So that's, I think, an important component. However, let's just address the issue, and I think that there might have been a question about the use of inpatient care. There are young people who will not use mobile response and stabilization, who will end up in inpatient care in New Jersey. Some of those young folks need to be in a hospital. Some of them, it's really a matter of the messaging and getting to families. It's usually not young people who have Medicaid. It's usually young people who are guided by their commercial insurance plans. Correct? Am I correct on all of that? Okay. Dante, you're up. So let's talk about this question of the use of inpatient care real quick, and the role of mobile crisis. I am guessing that you have really made an effort to keep young people in their own homes, correct?
Correct. This question is a difficult one for me because let me approach it this way. So there are a couple different layers to our PPOE. So it's what we call the electronic bed board. And if a child is in an ED, they're going to be transported directly from that ED to a crisis stabilization unit. And then there are the events that happen within the community where mobile crisis dispatch. The one point I was going to make on the last slide is that, or that I would add to this one, would be coordination. Georgia is a fragmented system. DBHED has primary responsibility for uninsured individuals, for my office children, or those with traditional Medicaid, which we partner with our Medicaid authority on. But there are not a lot of uninsured children in Georgia. Most have a payer, whether it's commercial or Medicaid. And managed care in Georgia has many of the covered lives, which is managed by a different agency. And, a tip of the hat to you, Liz. Several years back, at a conference, I think in Virginia, or were we in Maryland? We sat down at a table with you and our managed care organizations. And so really had a productive conversation that day that led to, it informed our reprocurement process, because one of the things that they shared is when our covered lives are served by your mobile crisis team, we have no awareness of that. So we can't provide care coordination after. So when we reprocured the service, there was some processes built in where when it was a managed care covered life, which has different provider network, different processes, so on and so forth, those managed care companies receive alerts or reports that their covered lives have gone into crisis, and they're able to follow up.
That's really helpful. And I remember that conversation now that you mention it. We're going to come back and talk a little bit about managed care, not today, but I'm going to be back in touch with you, Dante, about that work and how important that work is, and maybe try to connect some dots in a future discussion around the managed care work. I want to just make one, I think there's another question that came up, and I just want to make sure I get on, and that is, there's a question about getting the payer information from parents when they call. So I'm just going to touch on it real quick, that in New Jersey, in that single point of access, in that place in which people call, parents and caregivers call, they will collect the payment information if there's a commercial insurance plan or if the child has Medicaid. These are not preventative for a young person to get care, right? These are just really for understanding for the system. One is to make sure that there's a connection to the Medicaid record and making sure that we can see the other components, since there's real-time access to Medicaid information within the electronic record. But the other part is connecting the dots to other resources that might be available. So it's collected right up front. For the individual who asked that question, if you have more questions about when and how payer information is collected and why, we're certainly happy to touch on that. And I'm happy to follow up with you because I know that we're getting ready to run out of some time. So I'm going to give each one of you just 30 seconds to hit on anything that we missed in this conversation. We're going to start with you, Hazelyn.
Just that the centrality of family voice and choice in this process is key, and should never be seen as a barrier, but rather an asset to addressing the needs of youth and families.
Thank you. All right, Dante, you want to go?
No, I think the conversation was pretty robust. It's just, I guess what my 2 cents I'll leave is just, it's really complex. It's fluid, requires a lot of people, a lot of planning, a lot of coordination, and it's ever evolving.
I would absolutely agree with you. Danielle, I could give you a moment, and then I'll.
I don't really think I have too much else, except for if a family doesn't have any insurance, that's something that we do too, is that we will help the family fill out the paperwork needed so that they can get Medicaid or family care insurance as part of helping them link to resources. But otherwise, I think we covered it all. So.
Thank you. This is a wonderful panel. I just wanted to follow up on what Dante's saying, that this is really complicated work, and every state and every community is really different. What's important, I think, is that we really continue to try and get to that place in which parents are saying, caregivers are saying, even young adults are saying, hey, we're struggling and we could use some help, and to be able to get there at that time, which is incredibly complicated work, but certainly worthy of it. So for all of you who've joined us today, I want to thank you for joining us in this conversation, for sharing your questions, your comments, and all the things that you shared in the chat. And I hope to see you in a couple of weeks when we talk about someone to respond. I'm going to hand it over to the Institute folks.
Thank you for joining this month's Mobile Response and Stabilization Services Learning Community webinar. Please take a few moments to complete the evaluation for this webinar using the following link being posted in the chat. We will be providing a certificate of attendance after completion of each webinar being offered throughout the entire series. So make sure that you're registered with the same name logged into each webinar so that we can confirm your attendance and the total time you were a part of this webinar. Please allow up to 10 business days for your certificate of attendance to become available in Ideas at the Institute. Any presentations, resources, and webinar recordings will be made available to you within Ideas at the Institute. Once you are registered for the learning community, you will have access to all upcoming and previously recorded webinars. We hope that you join us again for next month's webinar. You can access the Zoom link for each webinar and download a calendar appointment for that webinar by logging into Ideas at the Institute. Access the MRSS Learning Community Curriculum and click the View button for the upcoming webinar. Thank you for joining us, and we look forward to seeing you at the next webinar.